is your experience? So those who can write it, who have some form of endotheliopathy.
Avascular blebs and these, the risks of blebitis and bleb-related endophthalmitis. Dr. Ronnie's pictures. So these collagen implants where trabeculectomy, you have the option of Mitomycin C, or do you want to use a collagen implant. So in the long term, blebs fail mainly due to fibrosis between the subconjunctival and the episcleral tissue. Now, a lot of wound modulating agents have been tried and tested, but eventually there are basically Mitomycin C and to some extent 5-fluorouracil. Even in 2002, nearly 68% of surgeons were using Mitomycin C in primary trabeculectomy cases. Now, why is Mitomycin C so popular? So it has been a tremendous value addition to TRAP. If you look at the avascular blebs and these, the risks of blebitis and bleb-related endophthalmitis. Dr. Ronnie's pictures. So these collagen implants where they come in different shapes and sizes. Most of us probably use the 6x2 circular ones. So how do they act? So it's believed that it has more of what we call as a regenerative approach. So these are porous materials. So the fibroblasts are able to proliferate into these porous materials, and theoretically a scarless tissue healing should happen, in contrast to the cytotoxic approach of mitomycin, which is complete cell death and apoptosis. So you find that in mitomycin C blebs, they look like this, large multiloculated fluid collections with blebs slightly on the thinner side. But with Ologen implants, you find that the blebs look a lot more physiologic. You don't see such thin-walled blebs, large fluid collections. And there are some additional postulated mechanisms as well, that they act as a mechanical spacer between the conjunctiva and the episclera, so that should theoretically have some impact on preventing fibrosis, and some tamponade over the scleral flap theoretically should be able to reduce some degree of post-op hypotony. So now these implants have been around for quite some time, and we have had multiple RCTs performed in multiple countries in the world. So an RCT performed first, it was published quite some time back from India. That is from LV Prasad. Then this is from China. You have RCTs published from Egypt, from Germany, from France. So multiple RCTs. So we look at the meta-analysis and see how these stack against each other. So the first meta-analysis in 2014, which looked at both these. At this time, the number of studies were a little limited, and they found that no difference in complications at this point of time. The Cochrane group came out with their meta-analysis in 2015, and it was interesting. First of all, they said that the quality of evidence was very low at this point of time, but they noticed some trends. Of course, these are not statistically significant, but at this point of time, they noticed some trends that at 1 year, the intraocular pressure was marginally higher with the Ologen traps, and its effect on reducing hypotony, which was possibly an advantage that is touted, was uncertain, and its effect on reducing other complications were inconclusive. This was in 2015, but they, as I said, noticed certain trends. So they found that the Ologen traps tend to have more vascular blebs, and the blebs were certainly thicker, and there was an early propensity towards early bleb leakage, and this was hypothesized that possibly the amount of the Ologen bleb initially, and if your conjunctival closure is a little more not as meticulous, you might end up with some early bleb leakage. And they found that with MMC traps, as I said, lower intraocular pressures at 1 year, but more chances of early post-op hypotony and late bleb leakage. So these were the trends noted. So the last RCT published was in 2019, meta-analysis, sorry. And they actually found that now the number of studies have increased. And the follow-up period also of studies have now gone up to almost 5 years. So at this point, intraocular pressure reduction alone, they found that actually mitomycin C was superior to Ologen. But if you looked at success rates alone, they were similar. So that is simply because you define success rate at a predetermined IOP. So if you determine the success rate at 18 millimeters, then you found that both these were similar. But the fact is, mitomycin was able to give you lower intraocular pressures in general, and there were two complications which were more common in the mitomycin group. That was hypotony, and the other is suture lysis. So you had increased incidence of suture lysis with mitomycin. And again, you can consider the fact that in mitomycin you are more concerned with hypotony and you might keep more tighter sutures, and therefore you end up with a greater incidence of suture lysis. With Ologen, you theoretically kind of feel that when you are doing the surgery, you have a tamponade over the scleral flap, and the general technique described is also to have a little more loose apical suture, so you end up having less of a suture lysis rates. So in conclusion, you find that these are only trends because there is no clear statistical evidence of an advantage of collagen implants over mitomycin. You probably have a trend of less hypotony and less suture lysis with Ologen traps with slightly higher intraocular pressure though. So that would be the trend. And now the problem is, which is the use case for these collagen implants, and that is the problem, because you have something which is increased cost and with no clear evidence of a significant advantage of over mitomycin C. And the fact of this matter is, most of the mitomycin C complications were from your era when you used much higher concentrations of mitomycin C for more exposure times, and therefore the use case of Ologen is a little difficult. And I think the only marginal use case would be when you are expecting a very high risk of MMC complications. Maybe if the other eye had a MMC related complication, or you are looking at young high myope patients, you can consider this. But that is probably the only marginal use case scenario that I can think of.